Welcome back again, friends. Today I'm going to talk to you about a very common medical and indeed a surgical problem that we face all the time in the clinical setting. And that's in relationship to gastro-esophageal reflux and hiatus hernias. This problem is very common and we encounter that a lot in actual practice. The first thing that you need to learn is the sphincter mechanism that stops the acid refluxing back from the stomach to the esophagus, and that's the area that we call lower esophageal sphincter. Now, there is no specific anatomic entity to it. However, there are a few mechanisms that will contribute to the constant high pressure at that area that will prevent the acids and the bile from refluxing back from the stomach to the esophagus. So it's a unique physiological entity as opposed to a definite anatomic structure. So the muscles of the esophagus, the smooth muscle, the circular layer of the smooth muscle, is thickened at that area and in a state of tonic contraction. It means that it has got a high resting pressure. And from those fibers, there is what we call the sling of the cardia. It's a smooth muscle fiber that are continuation of the circular layer, but it's run in an oblique fashion at the junction of the cardia and the fundus. And when we say the cardia, I mean the cardio-esophageal junction. In addition to that, we have the crura of the diaphragm. As you know, the diaphragm passes from the posterior mediastinum into the abdomen via the diaphragmatic hiatus, guarded by the left and right cross of the diaphragm. And because it's part of the diaphragm, it will contract during inspiration in order to compress the lower esophagus. And also the fact that we have a length of about 2 or 3 centimeters over the lower esophagus and the abdomen make it compressible by the intra-abdominal pressure. And these mechanisms, what are the things that constitute the lower esophageal sphincter. Now, hiatus hernia is a very common condition, but doesn't mean that you have to have a hiatus hernia to have gastroesophageal reflux. Indeed, a lot of the hiatus hernias that we see are asymptomatic and discovered incidentally, but we need to know a little bit about them before we proceed, because you can have a reflux as a result of defective sphincter or reflux as a result of having the hiatus hernia, which will weaken the sphincter. In general, patients present with heartburn, and then we think, do they have reflux? And if they have reflux, do they have a hiatus hernia or not? By definition, hiatus hernia is the anatomic problem that occur when the gastroesophageal sphincter migrates from the abdomen into the chest cavity, in particular into the posterior mediastinum. We tend anatomically to define them, as we can see in the picture, into 4 types. This is the normal anatomy, where there are 2 or 3 centimeters of the esophagus below the diaphragm. This one is called the sliding hiatus hernia, or the type 1, where the gastroesophageal junction is high in the posterior mediastinum. There is a rolling hiatus hernia where the sphincter remains in its place, but the fundus of the stomach herniates through and it can roll around the esophagus. And this type is dangerous because it can, in fact, lead to incarceration and devascularization of part of the stomach, and it could present as a surgical emergency where it needs to be repaired immediately. The third type is the combined one, where you have both migration of the gastro-esophageal junction into the posterior mediastinum, very high above the diaphragm, and also part of the stomach that doesn't get pulled up, similar to this one, but it goes in and it can roll around the lower esophagus. Again, this type is dangerous and can lead to incarceration. This is very uncommon type of hernia, though, but it does get encountered occasionally. And the fourth one is when you have other abdominal viscera that will migrate into the chest, and you'll be surprised how much of the abdominal viscera can get herniated into the chest cavity, including the colon and the spleen and the distal part of the pancreas. Most hiatus hernias are found incidentally, and they are asymptomatic. It doesn't mean they have reflux, and often they don't need to be fixed if they are not causing any problem. However, when we have big hiatus hernias, they tend to cause more symptoms, and we will come back to the symptoms later on. And these symptoms are not only reflux, but they can also be chest-related symptoms. What happens if we get reflux? So I want you to understand the pathophysiologic changes that happen in the lower esophagus and the consequences of that in the long term. So obviously it does cause heartburn and volume regurgitation, which we will discuss later. But how it happens and what it actually leads to. So the weakness of the lower esophageal sphincter, regardless of the mechanism that causes that, in particular in patients who have increased intra-abdominal pressure. And that happens basically in obesity, or in pregnancy, and if someone has large intra-abdominal tumor. Negative pressure in the chest, because the stomach gets pulled in the chest, negative pressure in the chest plays an important role in the pathophysiology of making the esophagus and the bowel to come back up to the lower esophagus and cause the damage. Very often you will see that people who have reflux, they don't really have gastroesophageal reflux, but they have what we call gastroduodenal reflux and defective gastric emptying, which means that there will be bile in the stomach. And there are theories that say bile is more traumatic than the acid to the mucosa of the lower esophagus, which is a sequinous epithelium. And the bile, particularly bile acids, are very dangerous, and they lead to ulceration. These ulcerations can be divided into 4 stages. So when the endoscopists look down in the esophagus and assess the degree of the injury to the esophagus by the acid, they describe it as grade 1, which is just erythema, and grade 2, which is usually linear ulcer, and grade 3, which is confluent ulcers, and grade 4, where you have a stricture. In addition to that, you could have changes in the lower esophagus that are pre-malignant, and this is called the Barrett's esophagus. And with Barrett's esophagus, you will have intestinal metaplasia of the epithelium at the gastro-esophageal junction, the squamous epithelium. And after the metaplasia, we will go into the grades of dysplasia from mild to moderate to severe, which is precancerous. Occasionally, the only time the patient has symptoms and they brought to our attention is that when they actually do have a cancer, which is adenocarcinoma of the lower esophagus. And Barrett's epithelium, when the endoscopists look at it, it's characteristic. It has got that salmon pink confluent color to it. Now we go back to the symptoms. What do they actually suffer from? Heartburn, and that's what the patient describes to you. Water brash. Water brash is difficult to describe, but it's just sudden watering in the mouth with a bitter, clear fluids that initiates nausea, and the patients go and need to have a drink to alleviate the symptoms. Regurgitation is a very common and very important symptom. That when the patient bends forward, and sometimes even without, they will get volume of the stomach contents that goes back up into the esophagus, and that's very damaging. They could get chest pain, chest discomfort. Also, arrhythmias are common. Symptoms are worse. Sorry for the mistake. These are worsening factors. They tend to be worse at night and when the patient bends forward to lift something off the ground. Smoking and coffee and chocolate will make the symptoms even worse. There is also a condition of what we call silent reflux, where the patient in fact suffers from early cough in the morning, sore throat, and wheezy chest. They usually get referred to the ENT surgeon for assessing the soreness of their throat, or they go to the respiratory physician because they have chest symptoms, and then they eventually will get found to have gastro-esophageal reflux. Now, these symptoms are typically relieved by ingestion of milk or alkaline fluid. Patients sometimes do have antacid medications or proton pump inhibitors that they will take on their own, and they will make their symptoms better. Be aware if there is any dysphagia, you have to ask the patient in particular for dysphagia. If they have dysphagia, then the problem is worse because dysphagia could be related either to neuromuscular problems of the esophagus, which are complex, and they need manometric assessment and further studies, or they have stricture of the esophagus as a result of chronic, ongoing, untreated reflux. And that stricture could be benign or malignant. We also need to keep in mind that people who suffer from symptoms of reflux and related to it, the symptoms could be exactly similar to peptic ulcer disease or to gallstone disease, and sometimes the reflux problem is actually associated with stone disease. And this is often the triad that a lot of patients will have at the same time. You will find them have gallstones, irritable bowel syndrome, and gastro-esophageal reflux. Now, how do we assess these patients? We've taken the history on physical examination, very unlikely to find anything, in fact. So once the patient has these symptoms, we will need to do the minimal of two things, which is endoscopy and an upper GI swallow in the form of barium or gastrograph in a swallow to assess them. Now, what are we looking for in the endoscopy is basically, as I said earlier, to assess the degree of the peptic acid injury to the lower esophagus. We will have to exclude more serious pathologies or different pathologies, such as cancer of the esophagus. Patient might have peptic ulcer disease. Patient might have cancer of the stomach presenting in the same situation. And if we see the finding, we document them. If we have early reflux changes, we do the grading of the severity of the reflux. If it is Barrett's esophagus, it's a different problem, and the patient will need endoscopy in 12 months' time, and that will be a different topic. The next one that the patient will have at least is fluoroscopic examination of the upper GI tract, including their swallowing, the motility of the esophagus, the anatomy of the esophagus and the stomach. If there is a stricture, we will see that. If there is a hiatus hernia, that will be demonstrated, and it will also give us an idea about esophageal motility. The other thing that we need to mention is that pH studies or manometry are not done on routine basis. They are specialist indications, and at your level as medical students, I wouldn't worry about them too much. We do them in the unusual cases where the diagnosis is not clear. Now, the usual treatment when you have got someone with reflux esophagitis is a medical treatment, which is successful in the majority of the cases, particularly in patients who don't have hiatus hernia. We give them diet advice to avoid things that precipitate the symptoms. We ask them to quit smoking if they are, and avoid chocolate and coffee. Often at night, elevation of the bed is very effective procedure to eliminate the symptoms that happen or worsen at night. The most common treatment that's indicated these days is the proton pump inhibitors, and I have got a picture here for the proton pump itself, and the inhibitor basically will reduce the production of the acid. Basically, what we will have the carbonic anhydrase here working on the water, leading to liberation of bicarb and consuming CO2 that comes from the interstitial space to form bicarbonate. So the proton pump will push bicarbonate to the circulation, and on the other side, the hydrogen will get pushed out by the specific channel that's called the proton pump inhibitor. And they are very effective. There are other medications, which are the antihistamine too, but we rarely use them these days. And as I said, most patients will settle. Occasionally, they will have relapse, or they need doubling the dose. And patients who have these symptoms tend to have them for life, unfortunately, and most of them end up being on proton pump inhibitor for life, or having surgery if surgery is indicated. If they have Barrett's esophagus, then we do a 12-monthly endoscopy and take biopsies to assess the degree of the dysplasia, because it's a pre-malignant condition. And now we come to the role of surgery. The indications have to be clear, and one of them is if the patient responds to the PPIs and the PPIs are not effective anymore, and despite doubling the dose and diet modification, the symptoms continue, and in that case, they will be offered surgery. People who definitely have symptoms of reflux and proven to have reflux, where they had initial response to PPIs and relapsed, are generally a good indication for surgery. Also, if they have only partial response, provide that we are certain they have reflux that was, say, demonstrated on endoscopy and burial study. Patients who have severe damage to the lower esophagus, and these could be ulcers, strictures, or Barrett's esophagus, particularly if they are young, and young is a relative thing. In general, if they are under the age of 60, they will also offer surgery, and there is proven benefit from surgery in these three indications. Volume regurgitation is a very disturbing symptom, and it's one of the solid indication for surgery. They tend to have respiratory symptoms, and they tend to run into multiple problems, and they have great benefit from surgical treatment. And the last indication is that if you have a young patient who's crippled by reflux and they do not want to be on medications for the rest of their life, and young here, usually the cutoff is 40 years old. But that's again depend on the discretion of the surgeon. They will benefit from surgery to avoid having ongoing medical treatment for the rest of their life. I will explain how surgery works to you, but only at basic levels. So what's the operation that get done? Now, if they have hiatus hernia, we reduce the the hernia from the chest, so the stomach gets brought down all the way down from the chest down into the stomach, and that step will be followed by repair of the right and the left cross, because there will be a big defect between the two crura, and then we suture them together by non-absorbable sutures, and that's called cruroplasty. We usually apply a mesh in these situations, and there are a variety of meshes that can be used to reduce the risk of recurrence, and the type of the mesh is at the discretion of the treating surgeon. We do fundoplication, the third part of the operation, and there are three types of fundoplication, as shown here. The gold standard is the Nissen fundoplication, which is the 360, and then we have the two-pair fundoplication, which is 270 degrees, and also there is the door fundoplication, which I don't use much, it's 180. The main problem with the Nissen that we worry about is the fact that it could be complicated by dysphagia if the wrap is made too tight. Also, there are endoscopic treatments for augmenting the lower sphincter to prevent reflux. There are a few proven devices, and they are increasingly used as an alternative to surgery. Now, surgery is always associated with risk, and before we embark on that, we will have to inform the patient about the possibilities that can complicate surgery. Injury to the esophagus, obviously that will need repair, and that repair could be laparoscopic, but sometimes you need to convert the operation to open. Pneumothorax, if we breach the pleura. Dysphagia, that happens when the wrap is too tight, so the surgeon has to be careful and make it loose and short, the fundoplication. So we call it loose and short Nissen fundoplication, which is the gold standard. Liver injury as a result of traction, also splenic injury that can lead to bleeding, all as a result of usually traction injury caused by adhesions between the spleen and the stomach or the esophagus. People will find it difficult to belch, but they need to know that, and also will complain of increasing flatulence, and occasionally you do have delayed gastric emptying, which tend to improve with time. So that's the end of the lesson of today, and I wish you all the best, and I will see you in a future lesson.